Welcome, everybody. I think we are ready to start. Welcome back from the coffee break for those who are in Washington. And welcome to the audience that is online. This is the session Incentivizing Quality Service Delivery in Schools, Lessons from the Health Sector. I'm your moderator for this session. My name is Mara Airoldi, and I am the Academic Director of the Government Outcome Lab. The lab is a research center based at the University of Oxford, and we focus on outcome-based partnership to improve social outcomes. So I'm very excited to be here today, being joined by our panelists and by the audience. The aim of the conference, as it was set out by the roundtable that opened the session, is to really take stock on what do we know about the use of result-based financing to improve educational outcomes. This session in particular is a bit different, is focused on exploring how and when result-based financing has been used in health to draw lessons that may be helpful for the education sector. There are clearly differences as well as similarities between the two sectors, and we will discuss them with our panelists today. And we want to discuss the potential, the lessons from using RBF in education, but also look in particular at the way in which this mechanism can incentivize quality in service delivery, both in health and education. It's my pleasure to introduce the panelists for the session today. We will have with us Fadila Kayod, lead economist at the World Bank, who has experience, especially in the use of RBF in Africa, and Middle East and North Africa, apologies. And she looked at different instruments. We have Dr. Wole Odutulu, who is a senior health specialist, again at the World Bank, who has a long experience on the use of result-based financing in health, especially in sub-Saharan Africa, Nigeria, and other Western African countries in particular. We also have Rose Tuyeni Peter, who is an economist who joins us from Percept Actuaries and Consultant, and Louise Savelle, director and co-founder of Social Finance UK. The way we are structuring our session today is that I will ask Louise and Rose to kick us off by reflecting and giving us a summary of a study they conducted for the REACH initiative. They will give us a brief overview of the insights of their study and their research on the similarity and differences between health and education, and what are the lessons that are learned by this comparison. And we will then move in a panel discussion where I'll invite Wole and Fadila to bring their experience to bear and reflect on the insight before we move to a Q&A with the audience in the room and the audience online. So we know further delay, I'll hand over the microphone to Rose and Louise to take us through what they found in their study. Over to you.
Thank you very much, Mara. It's a pleasure to be here today with such a great panel of speakers and to have this opportunity to share this research that Rose and I conducted alongside a number of other talented researchers from both Percept and JET in South Africa over the last few months. So it's a pleasure to be here. Before we kick off with any of the insights, we thought it would be helpful to give you a little bit of background on exactly what the research was that we did. So the work was commissioned by the REACH project with a view to really understanding what lessons can we draw from RBF in the health sector for education. It was undertaken by a consortium made up of social finance, with practitioners and specialists, predominantly in outcomes-based financing structures, by Percept, who brought a really deep understanding around health economics and incentives, and JET Education, who have a very deep understanding around the whole education space in low and middle income countries. The work, as it was initially framed, was quite broad, and pretty early on, in consultation with colleagues at the World Bank, we made two important design choices in terms of where to focus. The first was to focus on supply side rather than demand side incentives. So our work really looked at what works in terms of the delivery of services rather than in creating demand from patients or students to access education or health. The second choice that we made was then to focus predominantly on what we called process quality, so the quality of services, rather than predominantly on structural or facility quality and resources. And the reasons for this are twofold, and I think have been discussed in many of the panel sessions earlier today. The first was that we were very aware that the big challenge in basic education today is how to ensure that children are not only in school, but in school and learning. We've heard a lot today already about learning poverty. And we all know, I think, that big gains have already been made around school enrollment and access over the last 20 years. But those gains really haven't been accompanied by equivalent increases in learning outcomes. And the recent pandemic has potentially set that back even further. Similarly, our colleagues with a health background felt strongly that poor quality of healthcare as a driver of poor health outcomes is often overlooked still in favour of pushes for increased access to care. So overall, the comparisons that we're going to draw today are looking at lessons around, looking at what we can learn from lessons around driving quality of care in the health sector for driving quality of learning in education. Before we dive into the insights from our analysis, it's worth taking a moment to establish common terminology. So when we talk about results-based finance in this context, we're talking about programs where some or all of the payments are triggered based on predetermined results. And the goal of such programs is obviously to shift behavior, to use incentives and increased accountability to change results. One way to think of this is that you only pay for what you get as a funder. But as we'll see from our research, you also only get what you pay for. So as Mara mentioned in her introduction, before I hand over to Rose to talk through the insights themselves, I think it's really important to consider for a moment what we learned about or where the two sectors are similar and where they're different. As Mara mentioned, RBF has been used in health more extensively and over a longer time period than it has in education. And there's arguably significantly more research available around health RBF than there is around equivalent education. It's important to be mindful about the extent to which lessons from the health sector are really transferable to education, but it's plausible, we think, that key foundations of effective RBF in health may have analogues in the education space. Let's think a little bit about why. In terms of similarities, both health and education are public goods often delivered by the state. There are also sectors in which interventions become more expensive as they become more complex. So in the health sector, that might look like a transition from community health to hospitalization, whereas in education, it might look like the transition from early childhood education through to progressively more expensive and technical higher education. They're both sectors in which there are additional socio-economic determinants have a big impact on outcomes beyond simply the services that are delivered. So family education and income levels have an impact on both. And we know that limiting access through paid services impacts both population health and economic growth. It impacts usage. Both sectors are quite heavily unionized in most countries, and that is important from an RBF point of view, because we've seen in a number of programs that unions can be hostile towards the use of incentives and any new potential accountability mechanisms. And finally, in terms of similarities, we see common incentive problems across both sectors. So both sectors have some supply limitations around key infrastructure and/or consumable resources. Both sectors currently often have insufficient or inappropriate performance incentives for personnel. And finally, we see in both sectors some structures and/or cultures that may prohibit adaptation and innovation that could potentially improve outcomes, either at a facility or an individual level. So we think there's lots of ways in which the sectors are similar, but there are also some important differences. One of the key differences is around predictability of service. Access to health is episodic. Services are accessed over the course of someone's lifetime as and when they're needed. Whereas education is a more predictable service in lots of ways to deliver. It tends to be both sequential and linear. You progress from early childhood through basic education to secondary or tertiary. In terms of organizational structure, also, there's more linear progression in education, whereas in health systems, patients are referred up or down levels of care, from hospitals to local health centres to community-based care, as their health needs determine. Structural quality is arguably more important in health than education, and I think this is potentially a debatable point, but one that's worth noting nevertheless. To be effective, a health service really needs a reliable supply of medications and equipment. Now, education facilities clearly need to be safe and fit for purpose, but I think certainly at the earlier childhood education or basic education levels, a creative educator with a good pedagogical practice can deliver significant learning without extensive resources. So I think particularly at the more basic end of education, the earlier stages, structural quality is less important than it is in the health sector. And the final two pieces that we think are worth noting are around donor funding. Health sectors and health, particularly RBF programs in a lot of lower middle income countries, have tended to have a significant amount of donor funding behind them. That's particularly true in low income countries, whereas education is more often funded from national government budgets. The final difference, I guess, is then around provision. In the private health sector, particularly, we see over-provision as a key issue, particularly where there are fee-for-service models. In education, on the other hand, under-provision of services is arguably the bigger challenge. So we feel that that's really important context to have as we hand over to think about the results.
Thank you, Louise. So I'm just going to quickly speak to 12 key insights that we felt would be informative for education from the health RBF literature. The first of which is understanding the context. Of course, every context is unique and there is no uniform way of implementing RBF interventions. Therefore, it is really important to understand the location in which these interventions are being implemented. It's also really important that the actors being incentivized really understand how the RBF intervention speaks to wider policy goals and agendas. And it's also important to understand the political economy of the place in which these interventions are being implemented. For instance, the public financial management systems and also the degrees of decentralization of decision-making. These are really important to the long-term success of some of these programs. With points 2 to 4, these really relate to the design of the intervention. It's really important that interventions are, the problems that are being addressed are clearly identified. And especially when you're thinking of quality, which is often measured as a composite indicator, as a composite measure, it's important to choose underlying indicators that are really sensitive to picking up improvements in quality or showing improvements in quality. It's also really important to ensure that what you are targeting as your outcome is something that is within the control of the actors being incentivized. As Louise mentioned, there are a number of social determinants in both the health and education sector. And it's important that when we target outcomes, there are outcomes that are in the direct control of the actors being incentivized. Particularly when you're thinking of outcomes that are impacted by procurement or have to do with procurement, it's important to consider the value chain of the actors in the actors being incentivized, and ensure that all of the actors that are important for ensuring the outcome are incentivized along the value chain and are aligned towards a common goal. The fifth insight of interest is the purchaser-provider split. This is important for ensuring accountability and ensuring that the outcomes can be independently verified. The sixth and seventh point also relate to design. The size and timing of payments is important for ensuring that actors are adequately incentivized, and also when considering, considering facility level actors, it's important to ensure that the outcome, it's important to ensure that these facilities have the similar starting levels or similar resources to ensure and to ensure that the outcomes are comparable. Where they aren't, where they do not start at the same level, equity adjustments are important, or absolute rewards. Rewards should be based on absolute rather than relative progress. Points 8 and 9 relate to enhanced supervision. It's important that actors receive feedback, receive adequate and detailed feedback. And this also needs to be supported with increased financial support. And these two factors are really mutually reinforcing: enhanced supervision and adequate financial support to ensuring that that the outcomes are achieved. And the 10th point relates to the autonomy of how funds are dispersed, especially when incentivizing the facility level. The studies that we've looked at have shown that the most successful interventions are where agents have the autonomy in how funds are dispersed, particularly at a facility level. And this has the potential to improve outcomes beyond just the outcomes of interest within the study. But for this to be possible, it may also initially require enhanced feedback and support to improve adaptive decision-making and resource management. The last 2 points relate to monitoring and evaluation. Firstly, monitoring during the process of implementation is really important to ensure that there aren't any unintended consequences as part of the intervention. But also it's important to have a nuanced evaluation approach that allows you to understand the long-term impact of interventions and also to improve the overall body of evidence. So I'm going to stop there and hand over to my fellow panelists.
Thank you. Thank you, Rose. I can hear an echo. I don't know if it's just me. Okay, it has been fixed. Thank you for this presentation. The report is available online. We will put a link in the chat for those who want to access the report. I'll come back to you, Rose and Louise, after I gave a chance to our other panelists to come in. But I already anticipate a question I will ask you, which is, this all sounds well. And for those in the room who are familiar with result-based financing, probably it's no big surprise. And I will be curious to know what surprised you, what you learned from going through this process, thinking about health and education. But I'll come back to this question for you when we kick off the Q&A. I want to move on and involve our other panelists, Dr. Wole and Fadila. In particular, can I come to you first, Wole, with a question about, Rose talked about context as an important dimension to look at, and in particular, she mentioned the importance of the broader financial landscape that needs to be taken into account when one launches a result-based financing approach. And I was wondering if you can reflect on your experience around result-based financing in sub-Saharan Africa, and in particular, how this instrument fitted in your experience in this broader public financing landscape for health and education. It doesn't sit in a void. What role did it play or could play? What are the complementary intervention or technical assistance that might be needed?
Thank you very much, Mara. I think also to thank the audience and my other panelists. I think the question you ask is the core, the heart of this, what we are discussing here today. Understanding the political economy, of the country, particularly looking at the two sectors that we are considering today. I have a couple of examples that I want to share with you. I think the first thing to look at is to look at what are the challenges of the health sector itself. What challenges we have. In most of our countries, we have low coverage of key health services. You have fragmentation. Then you have inadequate resources in terms of the budget, that goes for health. And again, importantly, 10, 15 years ago, when REACH and HRITM, which is the health counterpart of what we started, what we have is, lack of focus on results. Government budget every year, spend on health and things like that. We are not looking at the outcome. What are we getting from our investment? I mean, this was not part of the thinking, of government at that stage. So we find ourselves in a very complex situation, and you want to look at where do we enter into this space, to be able to do anything. But some of the critical important things are also that we need to look at what are the prevailing policies, within government that can actually help you to be able to navigate and bring in innovation, to try and support government. I think in that wise, in one of the countries, we have a policy that talks about PhD under one roof, which is Nigeria. What that is looking at is that Nigeria already identified that they have a problem, with primary health care, and they're profiling some solutions into how to tackle it, building institutions, and looking at decentralization, local government, the district, the state, at the federal level. For us at the bank also, we look at the instruments that are out there, that we can use. What are the instruments out there? I mean, at the bank, we have bought ambulances, we have buildings, we supply drugs, we do everything. But at the end of the day, we can actually say that it has translated to health for the people. So what can we do differently, to actually get results? So if the orientation is results, then we have the example of what went on in Rwanda, Burundi, as at that time, looking at performance-based financing, from those continents. Again, I want to say that you also will need to do some special studies, to help you, to guide you in the design of the project that we're looking at. We have economic studies that were carried out. Who are the various stakeholders? What stake are they holding? Why are they important in this discussion? And that is critically very important for the success of any program that you want to run. Whether in education or in health, you need to be able to understand the dynamics of the stakeholders, within the sector. I think we missed an opportunity when I was in Nigeria. That opportunity was that, as we were having RBF in health, we were also having RBF in education. But we decided to pick on different states. I think it would have been very, very util for us now. I don't know whether I'm using it in English or French now. It has been very important for us, to learn in the same state, having education project going on and health project going, by the side, at the same time. We missed that opportunity. But I think Rose's presentation actually mentioned on many areas that are very important. But since we are talking of context, understanding the context, knowing the policies in place, knowing what can the instrument that bringing in, knowing how you want to adapt it, to the local situation, to the context in which you find yourself, they are very critically very important to the success of the program. I think I will stop here for now.
Thank you, Wole. It really highlights the art of designing an instrument, given that the context is so has such a great influence, and so there is no simple recipe. But thank you for drawing the attention on the importance of bringing the focus on results and tackling the issue of inadequacy of resources. And a really interesting example you brought to the table. Can I come to you, Fadila, given that your focus is education, and the study that Louise and Rose presented drew lessons from health in particular. And I would be really curious to hear what you made of it. and how your experience on the use of RBF. You have several years of experience under your belt of using this instrument in Sub-Saharan Africa and Middle East and North Africa. What are the challenges that, in your experience, RBF is best suited to address in the education sector in particular? And maybe if you can reflect on the role that this mechanism has beyond just the simple, like, improving learning outcome, but also on the system. Wole mentioned the importance of taking into account the local government, the district, the state. How does the RBF instrument sit in education in your experience?
Yeah, thank you very much, Mara, and thank you for having me on this panel. First of all, congratulations to the team who presented the study. Very important, but also very well structured in terms of findings. And I can see how many of these findings actually can be applied or adjusted to the education sector. And I think your question, Mara, is a really good one, because results-based financing is one of many tools that government at different levels have to try and promote learning. So it was the question of finding and using it strategically to address some of the key challenges that are bottlenecks to learning is really important. And I want to perhaps pose here a little bit of a counterintuitive statement, which is that in my experience, results-based financing in education works really well on problems for which financing is not the primary issue. So that's been really my experience using it in Africa and in the MENA region. And in the education sector, you are faced with many of such problems. And what I mean by that, and it's important to go back to sort of what does it take to produce learning? And producing learning is very complex and human intensive process. It really is a human business to teach children and make sure that they acquire the competencies that they will need for the future. And so to be able to do that, we really need to have a whole range of different stakeholders working together in the same direction. And I think it was WDR 2018, if I'm correct, that really emphasized the importance of aligning stakeholders, of forming a compact around the importance of learning. And so when you think about RBF and using it as a tool, my experience is that it can be very powerful at supporting alignment between stakeholders. What I mean by that is that you need to have, for example, different entities within the government. You need to have, for example, the Ministry of Finance and the Ministry of Education working very well together in terms of allocating resources where they are needed. So this process of aligning stakeholders doesn't usually require a lot of money. You know, it's more having people working together. But it is a process that is so important to achieve results and that can be really well incentivized with results-based financing. Another example that we supported in Morocco, for example, the government of Morocco is moving towards performance-based budgeting in education and having performance-based contracts being signed between the Ministry of Finance and then the Ministry of Education at different levels. So you think about the central level, regional level, district level, and then up to the school. So using results-based financing in that chain of results, what we thought or we found was actually very useful is not just the financing that is attached to it, but more that it creates a discussion and an accountability relationship between these different levels of providers that is really useful, because through the discussion of performance-based contract, they discuss, you know, what it is to what will I need to improve learning in this specific area of the country. what does it take to have teachers who are better trained and do a better job? So, and just those discussions in themselves, having a Ministry of Finance, a regional academy for education, a central ministry for education, just that process of aligning stakeholders can be extremely valuable to improve learning and to steer the system towards learning outcomes. So again, to summarize, and of course, you know, there are other ways that result-based financing can be useful, but again, thinking through some of those results, which does not, you know, they usually do not cost a lot of money, but they work really well in terms of being incentivized through results-based financing is something that, in my experience, has been extremely important in the education sector. Over to you.
Thank you, Fadila. This is a fascinating and a very concrete recommendation. I was frantically taking notes. Can I come back to you, Louise and Rose? I'll come to you, Louise, first. And you have a lot of experience in the design and delivery of outcome-based contracts in low and middle-income countries. And I was wondering if you can respond or reflect on what Fadila said and add your reflection on when result-based financing can produce meaningful positive outcome, both in education and health.
Sure, thank you very much. I mean, it's a great question, and I think Fadila and Wole have already touched on a lot of the things probably that I will say. I mean, the reality is that my experience is that the devil is in the detail. It is really important, as others have said, to really deeply understand the context and the existing resources, funding, incentives, who stands to lose as well as who stands to gain if those incentives change. I think there's a few pieces that really stand out to me, both from the research that we did and from my work as a practitioner. The one is around clarity. All stakeholders who are being incentivized really need to understand what they're being incentivized for and on what basis that will be assessed. Those same stakeholders then need to have the autonomy to do something different as a result. It's not enough to just have the incentive if they don't have the power to change how they're trying to deliver the outcomes that are sought. And the other piece, I guess, is time. I think one thing that really came through when we looked at the health literature was that in many cases, it could take 12 to 18 months for the practitioners who are being incentivized to even understand the incentives that were being put on the table with a sufficient amount of detail that would actually change their behavior. So I think overall, as Fadila was saying, it's just not enough to just put the incentives in place. And the conversations that happen around those incentives are really important at different levels. That certainly resonated with my experience. I think the level of support that those practitioners need is also something that both came through in our research and is also really kind of a key part of my lived experience as a practitioner. Delivery on a results basis is a radically different way to incentivize services, and support is needed to help the incentivized stakeholders around a whole range of different things. That might include resource allocation, how to allocate financial, physical, and human resources in a different way. It might involve data collection and interpretation, how to support stakeholders to measure and gauge whether progress is being made. And also data-driven service adaptation, not just the permission, but also the power to change what's being done and how. Just to pull back a little bit, actually, though, I think to pick up on part of the previous question, I think there's also some really important ways that the impact of particular RBF programs can potentially be bigger than the program itself. I think a lot of the components that make for successful RBF delivery are really also components that could underpin really strong policy implementation more broadly. So things like developing robust data collection and data systems. Those things not only inform the design, the delivery, the evaluation of RBF programs, but ideally have a broader impact in terms of creating an outcomes-based accountability across health or education systems. I think another thing is to think about kind of outcomes-focused governance structures, potentially driven from the top, and actually ministerial leadership was something that came through in a few of the examples that we looked at as a sort of key enabler to really shifting things and shifting behaviors on the ground at all levels. So thinking about what those governance structures look like that hold stakeholders accountable, and also potentially how to involve non-state participants in those governance structures. And then I guess the final piece I would add is how important it is to think about not only the incentives, but also the skills. And I think that's been mentioned by other panelists today. It's simply not enough to provide financial incentives if teachers or clinicians don't have the skills that they need to deliver better services. So thinking about training that sits alongside financial incentives is really what's needed to supercharge the impact of these programs.
Thank you, Louise. Often in the work that we do at the Go Lab, you reminded me that the use of an outcome-based approach is equated to a Trojan horse sometimes. And the idea is, well, you bring these instruments, this program, at what you really want to do is to shift the culture, the accountability, the way of thinking. And then maybe after having done a particular program with an RBF structure, you might do things differently, but yet you hang on to new habits, new way to reporting information, new way to make your decisions more effective. So really interesting. As an academic, I want to come to you, Rose, because I had a question when I read your report. You decided to focus on the supply side process quality instead of the service user demand. And that was a methodological choices. You didn't look at physical infrastructure and resources, as Louise said at the beginning. Can you reflect on what more is needed to do in your view to understand what more research is needed to unpack the potential on RBF? You scope your study in a particular way. Why that reason, and what else could you do? What is missing?
Thank you, Mara. I think so. Louise spoke a little bit to this in her presentation. In our sort of discussions around trying to understand the education and the health sectors better, or trying to help each other understand these sectors better, and we articulated some of the similarities and differences that we found. One of the major differences, or similarities that we saw, was that there seems to have been this improvement in access in both of these sectors. There are more children in school today than there were perhaps 10 years ago. In the health sector, where we see that access has improved significantly over the last decades. There's more access to doctors per 1,000 people, and access to medicines and vaccines and this sort of thing. But what we reflected on in the health sector was that while we have this increased access, but this hasn't necessarily translated into improved health outcomes. Even people who have access to healthcare still have poor health outcomes in terms of mortality and morbidity. And the recent Lancet Commission on healthcare quality has shown that healthcare quality is actually responsible for a significant amount of mortality among people who have access to healthcare. And our colleagues in education reflected that this is similar. And as one of the other panelists said earlier, education is quite complex in how it's delivered. There are a lot of things that go into delivering good education outcomes. So quality of teaching is also incredibly important in healthcare. So that's how we narrowed the focus of our report to see, well, how in RBF do you think about improving and incentivizing improved quality of service, and how can these learnings translate for the education sector. So that's why we chose that approach, and I think it led to some really interesting findings, especially since thinking about quality in healthcare at the moment is something that has become incredibly important with the salience of non-communicable diseases. And then when thinking about needs to be what sort of more needs to what more research needs to be done. I think personally I felt that there was a lot in the interventions that we read about that really described in detail the design of these interventions, and there was a lot of rigor in teasing out the quantitative effects, but there was still a little bit missing in sort of some authors described as sort of the black box, unpacking the black box of how these interventions really work. And I think this is something that more research or more writing is needed on, in terms of what exactly are the design features of these interventions that work. We know that in RBF, like, there isn't always, external validity with each and every single intervention. So if we're thinking of translating this into health, what exactly are the mechanisms, the key levers in the process that provide the desired outcomes, and why do these work in certain contexts and perhaps not work in other contexts? So that's something that I think perhaps requires a little bit more research.
Thank you, Rose. I'm keen to pick up some of the questions that have been posted, and invite audience in the room to pose questions. But before we do that, I would like to give a chance to each one of you to give a quick, like, 2 top tips that you want to leave with the audience, or things that you wish you had known 10 years ago in this sector. So if you were to start again. So 2 key takeaways. Can I come to you, Fadila first, then Wole, Louise, and then Rose? Fadila, your top tips.
Sure. Yeah. That's a good question. Probably more than 2 things. I wish I had known. But that's the good thing about getting old. So I think, and my response will be influenced also by what I just heard. And I think in education, it's really important to be mindful of what do we consider outcomes. The outcomes of, when we support a government or program, what is it that this program is trying to achieve? And one of the things in education is it takes time, again, to produce learning. It takes a generation to make sure that someone, has the skills, competencies, attitudes to be ready to join the labor market. So you have to take, a chunk of that generation. You can't be having a 20-year horizon when you design a results-based program. So how do you define, if your time horizon is 3-4 years or 5 years, how do you define your outcome? And very often you have to focus more on output, or even sometimes processes. And what are those processes and outputs that are really key to lead a country, a program towards, education outcomes? One of the things that, perhaps I should have paid more attention, or at least that now, I pay a lot of attention when I discuss with my clients in terms of where do you think you need to be in 4 or 5 years? How would you define that? And also, how are you going to make sure that you have the data for that? And I can come back to the data question a little bit later if we have time, but I think it's also very important. So perhaps I would mention that as one of the things that I try to be really mindful now that I'm older.
Thank you, Fadila. Wole.
Okay, thank you. I think I enjoyed the success of RBF during the day, and I have my regrets keeping me awake at night. When Rose was presenting, she talks about the provider purchaser split, which is very important. But within that separation of function, there is also the regulation function. Regulation function. My regret was that I didn't pay too much adequate attention to the regulation function of the Ministry of Health. In the design of the project, people have put more investment there to attract their attention and to perform that role very well. Even in many countries, in the US, in the UK, you have situations where you look at what we're calling, strategic purchasing. What is the specific problem of this population that I'm trying to solve? What is the problem in education in a particular province or a particular region? How can I use RBF to really, pump money or whatever it needs into that area to solve that problem? GPs in the UK are paid to particularly look for some things like checking regular blood pressure, obesity, and that is strategic purchasing. And it's a regulatory function. I think we missed that, and looking forward in the future, I think that's an area where it's critically important. The second regret that I have is which relates to sustainability. Is not, working with the Ministry of Finance as much as, we need to engage them with results and things like that. I have a good example in Zimbabwe where Ministry of Finance latched on very early enough, into the process. And this morning we had the webinar when we were looking at institutionalization of RBF in Zimbabwe, which is a success story. That was because the Minister of Finance was engaged and involved, from the very beginning. I mean, there are some other requests, but I leave those to some other days. I'll stop there now. Thanks.
Thank you, Ole. Louise and Rose, those I'm curious to see if you can top this advice. Like, this is gold. Louise.
I mean, you're right. These are lessons hard won. I think those of us who've worked in the space for a while bear the scars of less than perfect decision making. I guess there are sort of 4 ingredients, I guess, that I've taken away from this work that I will take forward with me into future work. I think one is time. Time to design the program properly, time to align stakeholders ahead of the program launching, and also then time after the launch to enable stakeholders on the ground who are actually delivering the services to understand the structure that's in place before expecting results to be delivered. I think the second piece then is trust. I think there's a huge amount of trust that underpins these contracts, not least the trust in the people being incentivized, that the payment that the way that their results will be assessed is fair, and that the payments will be made if they're promised. I think related to that then is autonomy. I think we really saw time and again from the health literature that actually where at least a proportion of results-based payments was coming back into the hands of facility managers who could then choose where to allocate that funding, the results were a lot stronger than where the incentives were just, for instance, going into the hands of clinicians or going up to a different non-clinic-based level. I don't know so much whether there's equivalent evidence in the education space at the moment, but I think that's something that would be really worth thinking about, is how do you create incentives at multiple levels? We know that in some studies there's individual payments or payments to individuals generate big results, but actually we saw in the health literature some really interesting phenomena around clinic level payments, where there was autonomy around how those were used. And I think the final piece then comes back to what I was saying before around support. This is a different way of working, and financial incentives without the support to help people to work in a different way just doesn't have the impact that we would want to see. So I think those are my 4 ingredients: time, trust, autonomy, and support.
Thank you, Louise. On the different level of incentive, I just want to draw attention to the work that my colleague Claire Lever is doing through a program called Deliver Red. It's not published yet, but she's looking exactly at that question, and she's looking at how the incentive trickle down in the system from the state, the district, the school. So looking forward to that research. Rose, take it away.
Yeah, so I think for me, two things have come out. The first one, actually, I think Fidela mentioned in terms of getting different, sectors of government to speak to each other. This is definitely something that I've learned in my work quite recently, that it's incredibly important to get the finance people and the service delivery people to come together and have conversations and, align them around one goal. I think the second thing is sort of, especially in an area like in a sector like in like healthcare, where outcomes are very, health outcomes are measured in lots of ways. You have to be quite careful what you measure, because that measuring certain things also creates certain types of incentives. So if you want to incentivize quality, you really have to think about how you measure quality on the side of both the service provider, but also from the side of the patient as well, and think about how you collect that sort of data to incentivize quality down the line. Because if you aren't measuring things that pick up quality, it might not be that you'll actually get quality healthcare in the end. So I think be careful what you measure, and be careful when you design those indicators, because simply measuring those things, even when you don't have targets, is already creating certain types of incentives and certain types of behavior.
Thank you so much. So we have some time to open the discussion and invite our audience in the room and online. I have some questions that came through the online audience that pick up on some of the points that you made. So I'll start picking up those questions, and then I'll ask some colleague in the room, and particularly Jess, if she can help me pick up 2 or 3 questions from participants in Washington. But among the questions that they came up online, one I think is for you, Fadila, because it's on data. And you had an appetite to come back to the data topic. And there is a question exactly on that. And the question is, as an awareness that data is a huge challenge in education. In particular, there is an issue of getting disaggregated data. We have data very aggregated, very difficult to use it for decision making. And she's asking if we've seen lessons from health on how we can collect and use data. So I don't know if you look at the data collection in health, maybe Wole, you can weigh in on what you've seen on the health sector in particular. What is the data element here? Fadila, your view, and then Wole, your experience on good practices in health that can be copied.
Okay, yeah, I can get started. So what we know of what it takes to produce learning is that it's about a continuous process of having a teacher somewhere in a country, and actually, thousands of teachers everywhere in a country delivering good teaching to kids who are ready to learn every day of the year. So Monday, Tuesday, Wednesday, etc. So for many days in the year, for many years, that process needs to be done right. That's how you produce learning. I mean, there are other things, but that's the core of it. And so if you want to measure results in education, unless like I was saying, unless you come in 20 years and you see what the kids have learned out of that, you need to be looking, so you can look at the end of the year, you can assess learning, you can see if there are some progress being made, of course, but it's a lot about behaviors. It's a lot about teachers' behaviors, children's behaviors, parents' behaviors, school principals' behaviors, and et cetera, et cetera. And what I think, at least in my experience, has been a little bit difficult with results-based financing is that we don't have really good way of measuring those behaviors on a very regular basis. There are some tools, including tools that are being developed right now and tested, but it tends to be costly. And it tends to be less available, let's say, than other data such as enrollment and things that we're used to. So the risk, and I think it was Rose who was saying that earlier, is that when government designs policies and programs that are results-based, they have to use the data that they have. And so they have to use data that are not necessarily the ones that are conducive to learning. They have to steer systems towards results that are not necessarily the one that will solve the learning crisis. So that whole science, in a way of how do you measure behaviors change is really core, I think, to making the best use of results-based financing to improve learning. So perhaps on the data agenda, of course, there are other things, and I could go on for a long time, which is also about how data are being disseminated and used transparently to also involve communities to make sure that parents participate and all that. But again, improving learning requires a set of data that is not necessarily the ones that government have the most access to. So now, Wally will tell us how to solve that.
Well, I would just say that maybe it's a bit simpler in health, because what we measure in health are really service outputs. How many kids are immunized, how many women deliver in the facilities, how many women came for antenatal care and this, which are, outputs from the services that are rendered. But we also have population level data, which are conducted, surveys which are conducted, periodically, depending on countries, depending on, the global effort towards data collection, like, DHSs and things like that, that looks at data in terms of, population coverage data, as it were. I think education also have EMIS, Education Management Information System, which are like the equivalent of health management information system that are output data, that are there. I think there are also learning assessments, that are carried out in education, which could perhaps compare with our population level, data that we have in health. I don't have the magic wand for how to do each country, as their own approach to doing it, but we have the DHIS2, that's what we call it, which is a program, developed from Sweden and being used in many, African countries, and perhaps the problem there, actually, Mara, is not that in health they are not collecting this data. The problem is data use. Are they using this information they are gathering to be able to make decisions? That is where we struggle. There are a lot of data on health, a lot of data, on health. And Rose and Luis will tell you that we got all this information out there. But how are our governments, the ministries of health, the ministries of education, how are they using this data to affect policies, to affect practice? I think that's the big problem, that we have in most of our countries. Not that the data is not there. One other thing that you should note also is that with RBF, the quality of data has improved because of verification. The quality of data has improved, But I'm not saying that we are there yet in those countries, but RBF has also contributed to improvement in quality of data, but data use is my concern. Thank you.
Thank you, Wale. Louise or Rose, do you want to come in on this, or can I move to a different question?
I think the only thing that I would add to that is that I agree with Wale that there are certain, like in health, we are very good at collecting certain types of data, and it is very sort of routine outcomes data. But with the growing prevalence of NCDs, we're realizing that some of the data that we have is just actually not good enough for tracking these diseases. And that this is sort of where I think some of the corollaries between health and education come in, because sort of tracking diseases that are much more complex and develop over a long period of time, such as NCDs, requires you to measure quality. And, you know, oftentimes when people are accessing health services, not all of the tests that need to be done to pick up some more complex illnesses are done. And, you know, some clinicians don't have the skill to pick all of those things up. So I think, you know, although I think, you know, health has made a lot of gains in terms of, you know, the quality of data we collect and how we use this data to respond to, especially as we can see now, infectious disease pandemics. When it comes to your sort of more complex illnesses, I think, you know, we have a lot to learn, and I think we're in this very much the same boat as the education system, and trying to understand how do you incentivize quality, and how do you measure things in ways that incentivizes improved quality.
Thank you, Rose. If it's okay, I would like to move.
There is a question in the room.
Yes. I was told so. I have my own spies. So
thank you to the presenters and to the panelists. This has been really rich and a really great, clear presentation of the issues. The session before this one was on teacher incentives, where we had a debate, you know, on the pros and cons of teachers' incentives, given that they are such a huge part of the government expenditures on education, right? Teacher salaries are the highest, so really improving their performance is key. And there was a long, very, very interesting debate about that. So I'm curious, are there any lessons from the health sector that we can learn from when it comes to incentivizing sort of frontline workers? You know, what is the debate in the health space? In education, it was, well, you take away their intrinsic motivation, you know, on the con side, whereas, you know, we had people arguing that it has been shown to be successful in some conditions. So I'm just curious, are there any experiences in health that can help us think about this in education?
Wale, do you want to go first?
Yeah, I think we have some things in the literature, you know, which I can pass to Jess to circulate to the needs of this panel discussion. But I will bring out one work that was done by she's now a World Bank staff, but she was doing these studies where she was doing a PhD at John Hopkins. I think essentially what that study said was the fact that in terms of, you know, having the incentives and the accompanying resources for, you know, operating costs at the facility level, that the intrinsic motivation, you know, of health workers, I mean, really come at, I mean, we have materials to work with. This is the work I love to do, and, you know, actually work in terms of intrinsic motivation. But in terms of the extrinsic motivation, you know, we have to consider many things. One is the fact that how much is actually this incentive compared to the salary of the health worker. That is a factor, you know, which makes me to want to work 24 hours, you know, instead of the 8 hours. I will look at most of the projects that I have seen, you know, what goes to the health worker may be between 5 to 15 or 20%, you know, of the salary, you know, of that particular worker, And I think also the economists will tell you that, you know, it gets to a saturation point. You know, when you get this, and it gets to a point when you can no longer, you know, push that person to want to go the extra mile based on the financial incentive that is receiving. Some people argue in terms of non-monetary incentives, opportunity to go for special training, recognition, community appreciation, and all this. But we all know it. The issue of incentive is something that we continue to discuss, for a long time. But my experience is that initially when they start, things get moving. But you get to a point, and I think that's what the economists are describing as the saturation point. It gets to a point when whatever you pump in, it doesn't really matter. If you're an economist, maybe you can. But that's my field experience, and I will circulate that paper for management.
Thank you. Any other views from our panelists on this question, or I'll pick other questions from our audience? Okay, so there is a question that is attracting some interest from the online audience. That is a quite generic question, and I read it out. How can we move from building or equipping clinics and schools to actual quality of service delivery? And is RBF the right tool to get there compared to other instruments? So I think this speaks right to the core of the study that Louise and Rose have done. So I'll come to you, Louise or Rose, first.
Rose, do you want to talk a little bit to how this plays through in terms of service quality in the health sector? And then maybe I can talk a little bit about the education space.
Sure, Louise. I think, as you said, Mara, I think this does speak to the core of the presentation. And I think just in terms of, answering the second part of the question first, is RBF the right tool to do this? It depends on the context. There are many different, ways in which, you can incentivize and improve quality, but you have to understand whether this is the right context for RBF. Do your payment and do your public financial management systems allow you, does your policy or regulation allow you to implement RBF interventions and, structure payments in this particular way? Is there enough decentralization and autonomy for facilities to be able to disperse payments in the way that works best for them? There are certain situations that lend themselves better for RBF than others. And I think also it's important to, when you're, as simplistic as this might sound, when you're designing these interventions, you really do have to consider what it is that you're targeting. Are you actually measuring quality, or are you just, measuring, other types of outcomes? So you need to ensure that you're incentivizing, you're designing incentives in a way that they do impact quality, but you're also providing enough support to your actors to be able to improve the quality of the services that the quality of the services that they provide. So I think it is like, there are many things that go into a good RBF intervention, but RBF is not the right intervention in every single context to improve quality.
Can I push you a little bit here and ask you to be concrete and give an example? Because you said there are situations that lend themselves more to RBF. Can you be specific? Like, for instance, if you have this, you do it, and if you don't, you stay away from it.
I think, speaking to the decentralization question, I think if you have a decision-making structure, for instance, within your health system that allows your facilities to spend money in a way that they believe is best when they are given an incentive payment, that works really well because those facilities have the autonomy to do so. In some contexts, this is not the case because it is very strictly regulated how and when facilities are able to pay their staff in this way, or how much bonuses are, or perhaps you have a sector that is very strongly unionized that will push back against certain types of incentives being paid. So that is so in a context where decision making is incredibly centralized, it might be a lot more challenging to implement an RBF intervention compared to one where you have more autonomy.
Thank you, Rose. Very insightful. Louise.
Yeah, so just sort of adding to that, I guess, with some thoughts from the education space, and really these build, I think, on points that Fadila made earlier around data in the space. I think agreeing on a timescale for the program that's realistic is really long, and by that I mean long enough to achieve really measurable learning outcomes. I think is going to be a key determinant of whether or not this is the right tool to use, as well as whether or not a reasonable metric of success can be agreed and defined and measured. I think one of the things that we reflected on as we were concluding our report was that actually there's a lot more research that's needed around whether and how RBF could be applied to some of to scaling up or rolling out some of the really well evidenced interventions around improving learning outcomes. So things like structured pedagogy, things like teaching at the right level. There are an increasing set of approaches that we know move the needle in terms of creating learning outcomes. What we don't know yet, I think, or what hasn't really been explored in depth, is whether there are sufficiently strong causal links, let's say, between some of the process or activity markers of those interventions and later learning outcomes for RBF to be really robustly applied to those without creating perverse incentives that we'll only learn about in 5 or 10 years. So I think there's some really important kind of questions around that. And I don't know, Fadila may also have some thoughts around that.
You are put on the spot, Fadila.
Sure. Well, a lot has been said, which I very much agree with. To me, and I think I'm repeating myself a little bit, and I'm starting to be a little bit of a broken record on this whole idea of behaviors. But I think what's at stake really in the countries that we work with is not to have one small or medium intervention in a given region of a country that will show results. What's at stake is really taking those education systems and making them more results oriented. That really is the core of the matter. And what we know of the many countries that we work with is that being more results oriented and producing better learning results has a lot to do with the way that the systems work, the governance, the functioning of these systems. Of course, inputs, policies continue to be extremely important to get learning. But increasingly, we also see that many countries have the right policies in place. They have the right inputs in place, and yet, learning outcomes do not materialize because there is a huge implementation gap between what is being decided and what is being done. So even that, I think, again, what I've seen in the countries that I've worked with is that results-based financing or results-based approaches, I would say, can be really powerful in changing behaviors. And I think all of you today have mentioned that, how, once you've gone through such a program, you change the way that you work. You change the way that you report on results. You change the way that you measure, you collect data, you use it. And I think that's the really important thing, that it can be, I think, a unique way for government to really try and influence the way that these administrations and these systems, from the central to the schools, act, work together, and work on and function on a daily basis. I don't see, and maybe after all, I'm not that old. I haven't seen everything, but I if you continue to be input-based in your approach, I haven't seen a model that was successful at changing behaviors, changing mindset using input-based. While results-based approaches, I think, have had a better impact in terms of changing the way those education systems function.
Thank you.
Thank you, Fadila. Ola, do you have a final comment? Otherwise, I will just bring the session to a close and highlight some of the key points that I am taking away.
Yeah, maybe just since we are talking about quality, I think for us in health also we have challenges, serious challenges with quality. I will just give two examples. One is neonatal mortality and maternal mortality. Covering data are improving immunization or antenatal care, but those two indicators. And what we have seen is that this is challenge of quality of healthcare at before delivery, at delivery, and the first 1 month of life. And what this will require is coming from the session we just ended is the knowledge, the skills, and the competence of the health workers to manage those situations. And what they have identified in literature is the no-do gap, which Rose referred to, which the studies referred to, that was presented to us earlier on. Many health workers know some of these things, but they don't do it. They know, but they don't do. How do we break those gaps? I think I will stop there. That is the challenge that we are facing. I think what we need to work on to be able to make significant impact on reducing, this mortality that we see with infants and with mothers and childbirth. Thank you.
Thank you, Ore. So I'm not keeping our audience more. It's late for many of our attendees. I just want to thank our panelists and our participants for such a rich discussion. I've been teaching policy evaluation for many years, and we often look at what you can learn from health policy and education policy. And despite the differences, I find that looking across policy sector really helps us to move outside paths that are familiar and help us to think outside the box. So we had a lot of that tonight with the importance of really looking at the human process elements and the need to change the behavior. That's not an easy feature. We look at the bigger scale of how it's important to look at the context and to do some tailored design of a program to tackle a particular problem in a particular place. We looked at the importance of having clarity in the design and matching the design with what we try to achieve, the importance of the autonomy of people involved, the importance of giving the time. So to big challenges, there are not easy solutions. So if overcoming the learning gap was an easy challenge, we wouldn't be here talking. So RBF probably is not the magic wand, and the lessons from healthcare don't translate immediately. But I hope you really enjoyed the discussion, you got insights, and I highly recommend you to go in the depth of the report. In the chat, there is a direct link to the report. And with this, I wish you a good continuation to the conference. I'll see you tomorrow, and enjoy your drinks if you are in Washington.